All right. Anti-ganglioside antibodies, and specifically antibodies to GM1, which is a ganglioside, a complex acidic glycolipid, glycosylated fatty acid, that's a part of the structure that helps maintain the integrity of peripheral nerve axon, and myelin. Those antibodies, if you see them, that's not a good prognostic sign. Usually they're associated with Campylobacter jejuni as a prodrome. That's also not a good the association with Campylobacter jejuni. That bodes poorly for the patients in general. And then if you do nerve conduction testing, I'll talk a little bit about that in a moment. And the amplitudes of the motor responses, the compound muscle action potentials, are below 10 to 20% or absent. That doesn't bode well for the patient either. So that means the patient is very likely to have persistent symptoms. So how do you investigate this disease? We're going to talk a little bit about the electrophysiology, just very briefly. But so that would show signs of a demyelinating sensory and motor polyneuropathy. That's what you're looking for. But often in the first week, the testing is not very helpful. The same thing with looking at spinal fluid. That's an important way to, important diagnostic test for Guillain Barre syndrome. You're looking for something called albuminemic cytologic dissociation, which is an elevated CSF protein in the absence of any significant white blood cells, usually more than 45 milligrams per deciliter of the protein, less than 10 white blood cells. And but in the first week, often this lumbar puncture is normal. It's not that sensitive. There's a delay. So you have to make a clinical diagnosis. You have to use your best judgment very often without having these other tests to shore up the diagnosis initially. And so if you think somebody has Guillain Barre syndrome, you just have to treat them as such. Sural nerve biopsy, I very rarely do that, but if you do that, you should see signs of demyelination, maybe with some axon loss and inflammatory cells. So I want to talk a little bit about nerve conduction, and this is the typical setup for a patient undergoing median motor nerve conduction. This is a handheld stimulator that is sending electrical impulses in this direction. This is a recording electrode and a reference electrode. And then these are compound muscle action potentials. This is a summated response, a summated waveform on an oscilloscope that's comprised of all the motor nerve axons that make up that particular motor nerve. And this is stimulating at the wrist, and then this is up at the elbow. And so that's why, so this is where the stimulus is, this line here. This one at the elbow is delayed because it's further from the site of recording. And then one can calculate a velocity from between those two segments, and there are other parameters that we look at as well that will help us to know if there's demyelination. So this is what we would see in a disorder where there's focal demyelination. This is the ulnar motor nerve, and this is the distal response, the compound muscle action potential. It's maybe a little low in the amplitude or borderline, but it's pretty normal. But below the elbow, there's a drop in the amplitude. It's quite substantial. It's about a 60% drop. That's known as a motor conduction block. That's a sign of focal demyelination of the motor nerve, and that would be in the forearm. And that's the hallmark of an acquired demyelinating neuropathy like Guillain Barre, or at least this form of Guillain Barre, AIDP. And the velocity is very slow here. It should be about 50 meters per second. It's only 22 meters per second. So this is the typical pathology of AIDP. These are inflammatory cells. This is H&E stain. These are myelinated nerve axons. And these inflammatory cells are T cells, but there are also a lot of macrophages. And this is an electron micrograph of a myelinated nerve axon shown in cross-section. And this is a macrophage that's stripping away the myelin sheath. And that's the typical finding if you do a nerve biopsy of a patient with Guillain Barre syndrome, or at least this most common form of it. So how do you treat Guillain Barre syndrome? Well, remember your ABCs. That's the most important treatment for any of these disorders that cause respiratory compromise. So supportive therapy. You assess for respiratory failure, but they also can develop autonomic insufficiency perhaps as often as 50% of the time, so they probably should be put on telemetry. And they need to have their blood pressure checked fairly frequently. And they can develop bradyarrhythmias. Those are the most problematic arrhythmias. They can get SIADH sometimes because of immobility. They can develop deep venous thromboses, and they need to be monitored for that. And then urinary retention is not uncommon due to autonomic insufficiency, which can occur with any, as I mentioned. And so, of course, intubation is key if they seem like they're developing respiratory compromise. External pacing, perhaps that's necessary in a very small percentage of patients who have substantial bradyarrhythmias, but that's something to consider. Ins and outs need to be monitored for anybody who seems like they're developing any problems with urination. And then if they develop SIADH, just treat it like you would any other patient with SIADH. Hypertonic saline is the key. And then DVT prophylaxis, especially if they're not ambulatory. So what can you do, though, to speed their recovery? Well, there are two therapies that have been shown to be able to do so. Steroids don't work. You can't give patients steroids. In fact, there's some evidence that it makes them worse. There are randomized controlled studies versus placebo, and we won't go into detail about them. The plasma exchange clearly is beneficial in speeding their recovery compared to placebo. And I typically give these patients, what I do is I remove 200 to 250 cc's per kilogram of plasma per body weight over 4 to 6 exchanges. And then IVIG, or intravenous immunoglobulin therapy, is the other mainstay of treatment. So you could pick either of these, and that's typically 2 grams per kilogram body weight given over 2 to 5 days. That's only been compared to plasma exchange. It's never actually been compared to placebo. But it's very clear that both reduce the times to initial improvement, both improve into independent ambulation, and decrease time on the ventilator. And that it's also important to remember, though, there is a potential side, besides the usual side effects of these medicines, potential problem that sometimes arises with either treatment is a rebound phenomenon. And that shouldn't be mistaken for either recurrence of Guillain Barre Syndrome or CIDP, as opposed, somebody developing more of a chronic form of demyelinating neuropathy. And that is, patients who are treated with these medicines within a couple weeks, sometimes they'll get worse temporarily, and then even though they've done really well initially, after 2 to 3 weeks. And that's probably as a resurgence of whatever inflammatory substrates are causing the injury to begin with. That can happen with either plasma exchange or IVIG, and then you just end up retreating them with the same treatment. So which one to use first is really a personal preference. There's no literature that suggests IVIG is more effective than plasma exchange. In fact, there is a study where there's plasma exchange is compared to IVIG, and then versus plasma exchange followed by IVIG, and the outcomes were all the same. It was a big multi-center randomized study that was done in Europe, and so you just pick one and you stick with it, and you don't retreat. You don't treat with the other. There's no reason to, and you definitely don't want to treat with plasma exchange after IVIG because you'll just pull that off, and there's no reason, and then you've wasted $10,000 worth of treatment. So at the University of Washington, we usually give IVIG in patients who are ambulatory or on the floor. This is our institutional bias, but if they've developed enough weakness they're in the unit, they're close to being intubated, or they're intubated, we usually do plasmapheresis. It's easier to give in the unit anyway. But there isn't any good scientific rationale for doing that. That's just the way we do it. So let's talk about the next most common disorder that we see that causes respiratory compromise. And 63-year-old man presents with trouble swallowing and speaking. He's got drooping of his eyelids and generalized weakness, and his symptoms fluctuate throughout the day. So fluctuation is sort of the hallmark of this disorder. On examination, he's got bilateral ptosis, and that's worse with fatigue. That's evident on exam. He's got dysarthria and proximal greater than distal weakness of both arms and legs, but no sensory loss, and his reflexes are normal. I didn't put that in there. So this is a patient with myasthenia gravis, and this is a disorder that it can present just about any time of life, not usually in young children, although occasionally it does. Typically it presents most commonly in women in the 2nd and 3rd decades of life, and in men in the 6th and 7th decade. And it's likely that testosterone has a preventative effect that prevents this from happening. And as these older men lose their testosterone levels wane, they're more prone to developing this disease. We don't know that for sure, but that's what we suspect. And overall, there's a 2-to-1 ratio of women to men, and that's just very true of other autoimmune diseases. The weakness fluctuates, it's worse at the end of the day or after exercise, and the predominant symptoms are ptosis or eye movement abnormalities, ophthalmoparesis, in maybe 60 to 80% of patients. Uncommon not to have myasthenics present that way. And rarely it can present with respiratory failure, but certainly patients can develop respiratory failure about as often as 20% of the time. They can go into what's called myasthenic crisis. So just in general, what are the typical signs you'd see in myasthenia? They can have fixed weakness, but then you try to activate their muscles too, get them to exercise against resistance to see if they actually get worse. And that's what we expect to see in myasthenia. They develop limb weakness that's usually more proximal, but they can also, on examination, often have involvement in extensor term communis muscle. I don't know why that muscle seems to be more involved in myasthenics than just about any other muscle, but it often is. That's the muscle that helps you pick up your middle finger. And then they have ophthalmoplegia or ophthalmoparesis with sparing of their pupils, but normal sensation and signs, and reflexes. So this is a patient who's looking to the left and here and can't, oops, I'm not sure I have my arrow here anymore, and clearly has a right medial rectus palsy, can't bring the right eye over, also has a left medial rectus palsy looking to the right, and maybe some skewing. And that's going to fluctuate because the myasthenic patients have fluctuating eye weakness. So what happens in myasthenia? This is just a cartoon showing normal neuromuscular transmission. And this is the presynaptic terminal motor nerve axon, the postsynaptic membrane. Well, you have action potentials that propagate down the terminal motor nerve axon into the presynaptic, and then what they do with the presynaptic terminal is they allow for vesicles of acetylcholine to be mobilized and then to fuse to the presynaptic membrane, and they then exocytose their contents of acetylcholine into the synapse, into the synaptic cleft. That diffuses across the cleft to the postsynaptic muscle membrane. That generates end plate potentials which depolarize the membrane, and then action potentials in the muscle and muscular contraction can take place. So it's important to remember that in myasthenic patients, or anybody, there's something called a safety factor. And the safety factor has to do with the fact that we have a certain number of acetylcholine receptors on the postsynaptic membrane, but we have an excess of acetylcholine that's available at the cleft at any given time. That fluctuates, but that safety factor is technically defined as the amplitude of the end plate potential over the membrane potential minus the action potential threshold. And in the eye muscles, where there are fewer motor units innervating in individual muscles to allow for fine movements of the muscles, that number is about 4. But in big muscles like the quadriceps, where there are overlapping motor units innervating multiple muscles, that number is more like 25. In myasthenic patients, the safety factor is greatly reduced, and that's why they are vulnerable to the effects of fatigue or fluctuations in acetylcholine in the cleft. So this is a complicated cartoon, but it's just showing this is the acetylcholine receptors. They have these 5 subdomains on the receptor. It's a ion channel that undergoes conformational changes, and then next to it, and this is on the muscle sarcolemma, I'm losing my, there we go, is something called muscle protein-specific tyrosine kinase, or MuSK. MuSK is important for helping to allow for clustering of acetylcholine receptors, and antibodies that target either of those 2 proteins cause myasthenia. Acetylcholine receptors much more commonly, as we'll talk about in a moment. And then in the extracellular, in the cleft, in the synaptic cleft itself, external to the muscle fibers, acetylcholine esterase, which hydrolyzes acetylcholine into acetyl-CoA and choline so that it can be taken back up into the presynaptic terminal. And then so there are medications that target that can help patients with myasthenia by allowing more acetylcholine to remain in the synapse at any given time. So about 80 to 90% of patients with myasthenia, generalized myasthenia, have acetylcholine receptor binding antibodies, but those numbers are much less with ocular myasthenics, maybe no more than 20 to 40% at best. So those are the most challenging patients I find, because the antibody testing doesn't help as much. And then MuSK antibodies are present in generalized myasthenics who are seronegative in about 50 to 75% of the time. So virtually every patient with generalized myasthenia gravis is going to have one of those 2 antibodies. And there are different features clinically for those two diseases. They don't look exactly the same, the MuSK positive and the acetylcholine receptor antibody positive. But for the sake of time, I'm not going to go into detail about that. Many patients with myasthenia gravis have thymomas, as many as 15%. And of those patients, 75% have antibodies to striated muscle or skeletal muscle. And we'll talk about why that is also in just a moment. Why do patients with myasthenia have antibodies that target skeletal muscle? So that's a question I'm going to answer in a second. So other autoimmune diseases are also very common in myasthenia, hypothyroidism in particular. And then that can also mimic ocular myasthenia because those patients can develop thyroid eye disease that looks very similar. And sometimes they can occur at the same time, and that's very hard to tease out. Sometimes it takes an MRI to see edema of the muscles. That would probably be the one way to be able to tell for sure that somebody had thyroid eye disease. And then pernicious anemia, vitamin B12 deficiency, connective tissue diseases are not uncommon either with myasthenia. So myasthenia gravis, what's happening with these antibodies are targeting, normally they're binding to acetylcholine receptor on these membranous infoldings that are on the surface of the postsynaptic muscle membrane. Within these infoldings are acetylcholine receptors, and there's these convoluted infoldings, and the reason why is to increase the surface area to allow for more expression of acetylcholine receptors. So what happens in myasthenia is that antibodies target these receptors, and there are secondary events that occur, inflammatory substrates that bind to the receptors, then they degrade the receptors and cause morphologic changes, so they become not only bound but dysfunctional. And they become quite edematous, those infoldings, and much less convoluted, so they lose their surface area, and there are fewer receptors to bind to. So this is what you'd see. This is what's seen in an ultrastructure. Here's the normal synapse. This is the presynaptic terminal, and this is the synapse here. It's very, very narrow here, and these are these membranous infoldings on the postsynaptic muscle membrane expressing acetylcholine receptors. And then here's a patient with myasthenia gravis. The synapse is quite wide. These infoldings are quite edematous and widen. So not only are there going to be fewer receptors that are viable, there are going to be fewer receptors that can be expressed because the surface area is reduced. And then the synapse is wider so that acetylcholine can also diffuse out from the cleft. And so there are a lot of reasons why patients with myasthenia gravis develop neuromuscular impairment as a consequence, for all those reasons. So patients with myasthenia gravis, about 15% will develop thymoma, and this is just showing an example of that. So a chest CT is indicated. You always want to do a chest CT in anybody you suspect has myasthenia, no matter what the age. So even older patients who generally don't have a thymus gland or much of a thymus because it's atrophic, usually you still would probably want to do a CT to rule out a thymoma, just to be very sure. And those patients, yeah.
Is that also true in the anti-MuSK patients?
No. Anti-MuSK patients do not develop, they don't develop thymoma, they don't develop, as far as we know, follicular hyperplasia, which is what this is showing. So on a microscopic level, seropositive myasthenics, those with acetylcholine receptors, develop follicular hyperplasia of the thymus gland even when they don't have thymoma. So the thymus gland is strongly implicated in this disease. And what we think happens is that patients who develop whatever, for either because of thymic hyperplasia or thymoma, they develop abnormal cells called myoid cells, which resemble muscle fibers. And those cells actually express acetylcholine receptors. And then the immune system targets those cells, seeing them as foreign, but then inadvertently targets acetylcholine receptors at the neuromuscular junction. And that's why we think patients would develop this disease. So Tensilon test is a useful test to help make the diagnosis. This is a patient who's given Tensilon, which is a short-acting cholinesterase inhibitor. And here he has complete ptosis, and then after 8 milligrams of Tensilon, complete reversal. This is a pain to give because you need to have patients on a cardiac monitor now. I used to do this as a fellow in the clinic where I'd put a butterfly needle in, just check their pulse and just check their blood pressure periodically. Our clinic managers will not let me do that, so I'd have to schedule a visit on 4 South, the ambulatory care center, to do this, so I don't even bother anymore because there's a better test, and I'm going to show you an example of this, or just as equally as sensitive tests. Both have probably about a sensitivity as 80% and fairly high, maybe not that high specificity, maybe about 80%. But that's called an ICE test, and I got this off, I should probably have my own video, I got this off the internet. So this is a patient with ocular myasthenia, presumed ocular myasthenia. Oops. So she has ptosis of the left eyelid, and then she's trying to elevate her eyelids, and she has fatigue. You see how her eyelid fatigues? So it almost closes completely. And now the examiner is trying to exercise the muscle on her behalf, so of course he's going to make her even weaker, because she can't do it herself. So she can't see anything out of that eye. Now she's resting her eyes. And so she should recover because she's resting. And now she got better. Now she's fatigued again. So now he's putting ice on her eye. And he doesn't do it for that long. He does it for about 30 seconds. I should do it for a couple minutes. So ice is thought to prevent the kinetic, or sort of slow the metabolic rate of acetylcholinesterase, prevent it from working quite as effectively, allowing for more acetylcholine to remain in the synapse. So she should get better after applying the ice. See, she gets better. So we just do this at the bedside. It takes 3 minutes. We don't have to do a tensilon test, which is quite a pain. At least now it is. Yeah.
When you do a tensilon test, are you also concerned about the hypothetical problem with the kind of muscle reaction that you can get from depolarizing neuromuscular blocking agents like OR that might cause like diffuse lesions?
So I think the question was asked whether tensilon testing could precipitate additional weakness. I think that would be a question if there was a concern about patients who have cholinergic crisis, that they're overdosed on long-acting cholinesterase inhibitors. But in a new patient is not on cholinesterase inhibitor, I'm not worried about that. But that's always a question. And you think a patient is in cholinergic crisis, they're in the unit, perhaps they're not intubated. Do you give them tensilon to figure out whether they're in crisis or they just are undertreated and they need more cholinesterase inhibitors? I generally don't do that because they end up getting intubated, and we take them off of their Mestinon anyway in the short term. So it's sort of a moot question, in my opinion. Okay, so the other diagnostic test for this disease is repetitive nerve stimulation. And I showed you normal motor nerve conduction, or standard motor nerve conduction, but one other way to do that, one other test is to do repetitive shocks at low rates of stimulation, 2 hertz. And the reason for that is that can temporarily cause a depletion of acetylcholine, being exocytosed from the presynaptic terminal in a patient with myasthenia. So typically we're looking for a decline in the amplitude in a patient with myasthenia of at least 10%. And then we usually see that by the 4th or 5th potential. Here are 10 potentials that are semi-superimposed, so we look usually at 10. They're getting these stimuli. Let's say this is the median nerve again, every 2 seconds, and they get 10 of them. And so we see a decrease of 17% here from the baseline, with a slow return back to the baseline after the 4th or 5th response. After a short amount of exercise, now it's only 6%. And that's because that's something called post-exercise facilitation, where there's transient mobilization of stored calcium, and calcium is important for mobilization of vesicles of acetylcholine to allow for them to be exocytosed, the contents of which to be exocytosed into the cleft. So that's why patients transiently get better with very limited exercise on this testing. But then after more exercise and resting, after a couple minutes doing that, they actually get worse again, and that's something called post-exercise exhaustion. So here, 30 seconds after exercise, there's a decrement of 24%, 60 seconds, 35%. It's only by 7 minutes out they start to get back towards the baseline, and that's because they deplete all the stored calcium that they have temporarily. It takes about 5, 6, 7 minutes for those stores of calcium to be repleted. So that's called post-exercise exhaustion. And those are the hallmarks of the electrophysiologic findings for myasthenia gravis. So why does that happen? Why do we see that? Well, the reason is normally by giving those repetitive shocks or temporarily reducing the amount of acetylcholine, the more shocks we give, probably because we're depleting calcium that way, normally, but it never goes below the safety factor, so end-plate potentials in the muscle membrane are always able to be generated. Myasthenic patients have a similar pattern of acetylcholine release, but they can't generate end-plate potentials when they go below threshold because they don't have enough viable receptors. And then these end-plate potentials are what's important to be able to generate a muscle fiber action potential, so they're not able to do that when they go below threshold. And the muscle fiber action potentials are part of these composite waveforms, these summated waveforms, these compound muscle action potentials. So those become reduced in amplitude in patients with myasthenia. We don't see that normally because we have a safety factor that doesn't allow for that. So repetitive neurostimulation is a fairly sensitive test. In generalized myasthenia gravis, it has sensitivity between 60 to maybe 80%, depends on the muscle. In some very mild generalized myasthenia gravis, less sensitive. And in ocular myasthenia gravis, again, not that sensitive, like the antibody testing. Of course, these aren't patients you're going to see in the inpatient service typically, because they're not urgent patients. They don't have to be managed by admission. So I'm just going to throw this out there. How do you diagnose these patients? Well, we usually do single fiber, and I'm not going to talk about that today. That's a separate talk. That's not important. That's not usually important for inpatient admission in myasthenic. You don't usually need to do that to make a diagnosis. So how do you treat myasthenic crisis? Well, supportive treatment, because 20% of these patients with myasthenia go into crisis. They develop respiratory failure. It's not uncommon. Endotracheal intubation, bradyarrhythmias, if there's any suspicion that they're over-medicated on their cholinesterase inhibitors, because that means they're hypercholinergic and they can develop bradyarrhythmias for that reason. That doesn't happen too often. And then urgent therapy, again, plasma exchange or IVIG, similar to what we do for Guillain Barre patients. It's the exact same protocol acutely. And then in patients later, or who are newly diagnosed, and maybe they go into crisis initially, we treat them with cholinesterase inhibitors. We don't do that when they're intubated. We do it after that, after they're extubated. And then we put them usually on steroids, prednisone, and then usually at some point, maybe even during that admission, a steroid-sparing agent that will allow for us to take them off of prednisone eventually, because prednisone works quickly, but it has toxicity issues. Steroid-sparing agents work slowly, but have much less toxicity. So azathioprine, first choice, mycophenolate mofetil second. I use methotrexate as my third choice, cyclosporin. And then thymectomy. I typically do thymectomy in any patient that has thymoma, of course, and then those who are usually post-pubertal up to maybe the age of 60. So after 60, patients don't have a thymus gland, so we don't typically. So we don't do thymectomy under those circumstances. And about 85% of patients go into remission within 1 to 5 years. That means half of them can go down on their medications. They go into sort of chemical remission or medication remission. The other half can go into complete remission. Okay, so I'm going to finish up by talking about this Guillain-Barré patient to illustrate when it's appropriate to bring a patient into the unit and intubate them. So this is the same patient, the same scenarios. The patient presents, here the patient initially has mild numbness and gait impairment, a little bit of weakness, diminished reflexes, looking like early Guillain-Barré syndrome. So the next day the patient developed more substantial weakness, distal greater than proximal leg weakness, MRC grade 4 out of 5, but was still ambulatory. It's actually gotten, I forgot to mention, the patient started on IVIG the same day as admission, and then this is day 2 out of 5. She had some lability of her blood pressure, but it was less than 30 millimeters difference, and her telemetry was normal. And she developed a little bit of SIDH, but it wasn't that bad. It was about 128 or something like that. And her forced vital capacity was 25 milliliters per kilogram body weight, and she had a forceful cough. So at this point, I'm going to throw this out there. Should this patient have gone to the unit or stayed on the floor? Is it appropriate to keep them on the floor? So, residents, any thoughts? A 50-50 chance. Remember what I said about the 20-30-40 rule? So she's not below that threshold for vital capacity. She still has a pretty good cough. We also talked about other parameters that are important to consider for whether, the threshold for intubation. She still has a good cough. So I'd say it's probably safe to keep her on the floor now, or still. Then day 3, the patient was noted to be weaker. She had MRC scale, just in general, 3 to 4 over 5. Couldn't walk but could still stand. Still the same lability of blood pressure. It's still less than 30 millimeters difference. Her forced vital capacity is the same, unchanged. She has forceful cough. What do you think? Should she stay or go? Stay on the floor or go to the unit? Any 50-50 chance?
I recall from last year that the next
Yeah.
night she's still on the floor. So,
You already remember.
the slide after that,
You
she
already
goes to
remember.
unit, so.
So you know. So she's still on the floor. I think it's reasonable to kept her on. She's, because she can still stand. She's coughing okay. Doesn't have a lot of lability or blood pressure. Her respiratory parameters are okay. But in the early evening of hospital day 3, she starts to develop some difficulty swallowing, and she has some facial weakness. And she's got lability of blood pressure, but it's more than 40 millimeters variability. Her forced vital capacity is 15 milliliters per kilogram, and her cough is now slightly weak. And now should she stay on the floor or go to the unit? Yeah, she should have gone to the unit here, but okay, I'll tell you what happened though. In the late evening of hospital day 3, the patient reports weakening dysphagia, dyspnea requiring 50% oxygen by face mask, and she's got more facial weakness and worsening lability of her blood pressure and heart rate. And she had forced vital capacity of 10 milliliters per kilogram and weaker cough, and we already know she should have gone to the unit. And then she goes into cardiac arrest and undergoes cardiac resuscitation and intubation, and then she goes to the unit. Okay, so we already know the answer to this. Should elective intubation and MICU transfer have occurred earlier? Yeah, I think that probably would have been a good idea. Okay, so this is not the best slide, but so when do you bring patients into the unit who have Guillain Barre Syndrome? This is applicable to myasthenia gravis. I don't know about that so much, but I guess you can extrapolate a little bit about that. There's a lot of overlapping features between a patient with Guillain Barre Syndrome and a myasthenic in crisis. So there's a study that was done by this group called the French Cooperative Group on Plasma Exchange of Guillain Barre Syndrome study group, and they looked at early predictors of mechanical ventilation in Guillain Barre Syndrome. And here's some of the salient. So they compared those who didn't end up getting intubated, those who did. And there are a lot of salient features. I don't think I highlighted this. Even the age, as I mentioned, there was a predictor of intubation. As I said, older age is a poor prognostic sign. But difficulty standing, or inability to stand, that was statistically, 84% got intubated versus 56% who didn't. Facial weakness, 23% versus 11%. Inability to count to 10 in one breath, 25% versus 2%. Was that 2%? Yeah, that's 2%. And ineffective coughing, quite different, 32% versus 2%. Fluctuations of blood pressure greater than 40 millimeters of mercury, very different. So it was at 26% versus 11%. So those are some of the features that I was trying to emphasize with this patient. So at this point, hospital day 3, when the patient started to develop some difficulty swallowing, had facial weakness, and they had this lability of blood pressure greater than 40 millimeters of variability, in particular, they met the threshold for the 20-30-40 rule. This patient should have gone to the unit, for sure, and been intubated. So in conclusion, in any of these diseases, I'm talking about primarily, we talked primarily about those disorders that cause respiratory compromise. Those diseases, supportive care is paramount. In patients with myopathies, we can go in detail about that because you're not going to see as much of that. IV hydration, diuresis, measuring urinary output is key. And then in patients with Guillain Barre Syndrome, myasthenia gravis, and botulism, early intubation and cardiac monitoring is crucial, especially for the first disease. For the cardiac monitoring. And remember the 20-30-40 rule? And then Guillain Barre syndrome myasthenic patients can recover quicker, well, Guillain Barre in particular, with immunomodulatory therapies. I mean, myasthenia patients, obviously you need to give them these treatments so they won't be extubated. And those include IVIG and plasma exchange and then immunosuppressants of all the kinds I mentioned for more long term. So I'm happy to stop here and take some questions if there are any outstanding questions. Yes, Haas.
Dr. Weiss, before this patient quite met the criteria for going to the ICU,
Yeah.
How often would you want a clinical exam for spinal capacity? Like once every 6 hours?
That's a good question. We were doing generally the most you can do PFTs on the floor, I think, is 3 times a day. I'm pretty sure about that.
So more than 8, once every 8 hours just can't be done?
I don't believe so. So if you think a patient needs more frequent vital capacity measurements, you have no choice. You have to bring them into the unit.
So,
but of course,
so you would excuse me for taking that patient for having a little bit of a lower threshold.
Yes.
Before taking the patient
Yes.
to the meeting,
I would never fault anybody for having a patient go to the MICU sooner rather than later. I guess one could argue, should every patient with Guillain Barre Syndrome go to the MICU? Well, I don't know. I mean, if you have a patient who has just some mild leg weakness, they might, and you're not, I guess you can wait until they plateau, but the MICU is pretty tight on beds all the time. I really hate to sort of tie up the beds with patients with mild Guillain Barre Syndrome. On the other hand, probably can make an argument for that.
Yeah, well, but the patient who can't like walk or something like that, even though they could stand, I would think at that point they probably would have seen.
I think that wouldn't be unreasonable. Yeah. Any other questions? Yes, Brian.
So we had a patient recently at the VA that you probably remember where he got protastigmine, but it didn't help. And they couldn't get an NG down him. And so then, and the steroids were started, but they didn't help either.
So the question was asked in a patient, was the patient in myasthenia crisis and intubated?
That was a new diagnosis.
Okay, and this is patient with acetylcholine receptor positive antibodies?
I think that ended up being the case.
Okay, so the question is, why would some patients with myasthenia gravis and acetylcholine receptor binding antibodies not respond to cholinesterase inhibition initially? Well, it might depend on the dose. I don't know what dose you started them or what you brought them up to.
It was pretty high.
Was it? So I've had patients on as much as 600 milligrams of pyridostigmine a day plus 180 milligram time span at bedtime, and they need it. Some patients just need it. Now, why that is, I don't know. But remember, also, if the patient is fairly significantly affected, there is initially maybe you just have binding of the receptors and not as much of the morphologic changes. But if you have patients fairly weak and is fairly, has fairly substantial turnover of the receptors, and they might not have enough viable receptors for it to make a difference. And sometimes that happens. There's some patients with very chronic myasthenia who've just not been treated for a while. There's this idea that maybe over time, from turnover of receptors, you get secondary myopathic changes. And you can actually see changes in EMG sometimes, like you do in Lambert-Eaton, that look like a myopathy in extreme cases of myasthenia gravis.
And here's so he ended up having to stay in the unit, as Jen is pointing out, to receive neostigmine.
Oh, so that might be more of an absorption question, that he just didn't absorb pyridostigmine because he was getting neostigmine IV. So it just might be that for whatever reason he wasn't absorbing it well. I don't know why he didn't. Maybe he has some malabsorption syndrome we don't even know about. That would make sense to me. Any other questions? Oh, well, I think I answered the question. So the question was, what this patient responding briskly to neostigmine but not at all to pyridostigmine. And that, I think, has to do with perhaps for whatever reason that patient was not able to absorb pyridostigmine effectively, and I don't know why that would be for that particular patient. So was a very reasonable thing to do, to try neostigmine in a patient who failed pyridostigmine, but it doesn't happen that often that you have to go that far. Well, any other questions? Well, thanks very much. Appreciate your attention.